Hi, Mike Gibson, coming live from AHA 2022. I'm here with Jamie Jollis and, Jacqueline Tamis-Holland, and we're talking about an update in how we're doing getting people with STEMI care to the cath lab quickly, getting those arteries open. Time really is muscle. I don't think that's changed, but we seem to be falling off a bit in our ability to get the job done quickly. Talk to us about what you found.
So we looked at the data from the Get With the Guidelines CD registry, which is one of two national registries, the other being in the NCDR chest pain MI. And we started our look in 2018, second quarter, when the data were most complete. We went through the third quarter of 2021, because this analysis took us a year actually to complete and get published. And during that time, we looked at the standard metrics because I know maybe it's controversial, but ever since Jennings and Reimer and time is muscle, certainly it's something that seems to follow as a cardiologist. And we look at certain processes. So this whole quality improvement process is around times. And I know people get tired of the times. I know they get tired of trying to be 100% on the times. But the real time would be from symptom onset until you're treated. And in our metrics, we can much more reliably measure when you reach the medical system. And for people who get transferred, we can measure that reliably when you get to the first hospital. For people who come by EMS, we measure that when the paramedic is eye to eye with the patient. And people who come in the hospital door, it's when you get to registration. And so looking at our data was actually quite surprising. Three things. First of all, people who get treated fastest are the ones who call EMS. But obviously this is an observational study. We're not here to prove any therapy works. We're just seeing how we're doing. But they're also sicker, and I'm guessing that their symptoms are so bad they call 911, so it's a real bias. The next fastest would be those who walk into a PCI hospital, which is primarily, we had 601 hospitals in our study, and 500 were PCI hospitals. And the third is the transfer patients. And it's a smaller group, it's 25,000 out of 116,000 patients. But their average time from symptom onset to treatment was 240 minutes, really measured in hours.
That has not changed since the 90s. And 225 minutes median. It's like an atomic clock. 225 minutes median for these people to get the job done. And we're not doing much in the symptom to door time. We haven't really done anything to really improve that.
Yeah. So there's the three ends. One is symptom onset to calling, and there's been a number of attempts at that. We still work on that a lot.
We haven't had a lot of success. But
we haven't. On the back end, it's the cath lab time, and Jack and I were talking. The cath labs work. Once an interventional cardiologist is involved, the team's involved, you're getting treated. We see the same times, fast times across the whole country. That's not the issue. The real place where we think that the changes are and where we see the differences in outcome is from the medics. When they diagnose a STEMI and activate a cath lab, they can do that ahead of time. That appears to be associated with a much lower mortality. And this transfer piece we talked about, just in a really difficult situation, almost to the point where you might say, if you can get to a cath lab hospital in an hour, which is not often possible because of limited resources and long drives,
bypass the outside hospital, get to a primary PCI center. Yeah.
And then you and I go back to when I was an intern enrolling patients into your trials. That thrombolysis done quickly really can save things. And we're seeing an increase in thrombolysis use in transfer patients.
Well, I used to say, the fellows used to laugh at me, I'd call it a primary angioplasty if we got the person to the cath lab in 60 minutes, secondary at 2 hours. Tertiary at 3 hours, and quaternary angioplasty, post-MI care after that. But what's so sad is with these interhospital transfers, we're doing a lot of tertiary angioplasty. I still, in my heart of hearts, think that a facilitated approach might be better. I know all the data, but there are like real limitations to some of the data. When you gave a lytic in some of the big trials, they didn't do as much PCI in those patients. They sat there and they stared at an open artery in the cath lab. Well, it's no surprise. After a lytic and not stenting it, you're going to have a higher rate of recurrent MI. I think had we been more aggressive, or if we redid these trials now in a new era.
They did redo the trial, and I think that nobody pays attention to it in the United States because we all do PCI.
Correct.
But the STREAM trial looked at this exact scenario. Primary PCI, for people who are going to have a longer delay than an hour, or do the lytic and immediately transfer and do the cath
And
with
do-
the intent to do
with the
PCI,
intent to stay.
as opposed to the older trials which waited
Correct.
a couple of days or
Right.
whatever. And actually, it did show that they had similar outcomes.
Right.
So I almost feel like looking at these times, they're absolutely amazing. What was it? Fewer than 20% of patients coming from transfer to hospitals met the 120-minute mark.
Yeah.
And that's like unreal to me. So I think we either need to reconsider the transfer process. There's sometimes a lot of relationships. Hospital has relationships with other hospitals, and so they transfer much further along. Instead of going to the nearest PCI hospital,
Oh,
they
boy.
transfer to their hospital that they work with. Or we need
Or
to
that's part of their corporate structure.
Right.
Right.
Exactly. Or we need to consider other things. And we hate to talk about lytics, but that's why there's a 120-minute cutoff. Because if you don't think that systematically you can do that with all of your patients, or it's 75% of your patients, then you should not be having a protocol in place to transfer these patients.
We've also lost our reflexes, right? I mean, I get called at the hospital when people are like, oh, I hear you know how to do this thing called thrombolysis, and like the ER docs don't know how to do it. Cardiologists don't know how to do it. I think I'm the only one left I'm the oldest guy in the cath lab now. The only one left who knows how to give a lytic.
Emergency physicians are terrified of lytics.
Yes.
I used to, twice a year, I'd pull over on the side of the road with my computer. We'd have a course on how to give thrombolysis in the state of North Carolina. You have to keep refreshing. It's got to be easy button. You've got to work with the nurses actually who run the ER protocols for the locum tenens provider there. It really does need to be a lot of training, a lot of programming. It's not easy.
Yeah, but I'm almost worried because I don't want the take home is lytics. I think the concept really is figuring out in your hospital the best process of care that's going to work, and whether that be for your emergency cases, perhaps you do transfer only to the nearest hospital, even if it's outside your network. But figuring it out, and if you're in Hawaii and you have to go to another island, of course, lytics is going to be the case. But I think it's just really looking at your processes of care and figuring out what you can do better.
Right. And looking at your data in your paper, I mean, there was some recent slippage. We're not getting better. We're going backwards.
Yeah.
And that was associated with higher mortality. So,
Yeah, so that was very surprising. And actually, even before the pandemic started, we were going backwards. But to be on the positive side, these hospitals participating are really focused on quality and want to know this information. We had a bit of a black hole in information from 2015 till 2018 when the databases were being split apart. And then after quarter 2, 2020, that's when the pandemic hit. And this is not a paper by the pandemic, but we do know we had 100,000 additional cardiovascular deaths during the 2 years of the pandemic. And you can see it in our data, at least one side of the elephant, that we've seen mortality increasing, treatment times increasing, and we all lived through this.
Yeah.
The ERs were packed. It's hard to get transfers going.
a lot of delays. People were delaying coming in.
Yeah.
We were delayed getting them to the cath lab. So, and all put it all together, the mortality was higher.
Yeah, we sat around with the pandemic and tell me that there's no one coming with STEMIs.
Yeah, we didn't have any STEMIs. I mean, it wasn't even Myocardial. My interventional fellow was thrilled the first day we had a STEMI because he had been taking care of COVID patients on the floors.
In our CCU, I had 30 deaths in one week. It was terrible. So I had 3 people, and it wasn't COVID. It was these late presenting cardiac shock were not in the database.
Yeah.
All right. Well, we got to get back on the horse. We got to do better. Got to make our systems better. Get back, achieve our goals, and rethink maybe how we're doing things. Right.
I think it's about leadership. So, as healthcare providers, especially as cardiologists, we love this stuff. There's nothing more, for me, more fulfilling to take care of a STEMI in the cath lab or in the CCU. But we need leadership, so we need to encourage paramedics that are really struggling right now just to be trained and have enough coverage. We need to give them leadership to help them do their jobs and be able to diagnose and treat people like this. We need leadership for emergency medicine. They've been great colleagues with us. Lee Garvey, our colleague in New York City, set up some protocols there. Re-engage them and help support them. It's really leadership we're talking about here. Not beating cath labs up, but rather getting out there publicly and saying this is what needs to be done.
Yeah, and working with the EMS. I think that, like you said, leadership, but also just there's so many ways of talking to us and have parallel processes. Our cath lab is coming in while the patient is being transferred for a half an hour to the hospital. So we're both arriving at the hospital at the same time.
Well, so much of STEMI care I see is moving more and more into the pre-hospital setting. I'm doing several trials now where we're giving drugs in the field once the diagnosis is made. As we have more and more wearables, patches you put on your chest and things you touch to say, you know, am I having an MI?
Yeah.
And you spit into a tube and it tells you if you're troponin positive or not. We're going to move more and more care to the pre-hospital setting. So we've got to prepare for that. I do think we have to cement that relationship between the EMS system and the hospital. Get the ball rolling quickly. I think we can do a lot better. It is leadership. And thank you for your leadership. And thanks to all of you for joining us here live from AHA 2022.